All right, guys, welcome back to the Fill Me In Pod, where we dive deeper into the world of aesthetics. Hi, Nicole. Hi. We're filming from the lovely Denville, New Jersey, in your new space. Can I say that?
Yes, yeah.
So exciting.
I know it's going to be announced. And
I love it. When's it going to be announced?
Tomorrow, so June 10th, 10 a.m.
How long have you been keeping this secret from people?
Since March.
And you've actually kept it a secret?
Yeah.
Scandal.
Yeah, we're good at that. We're really good at that.
Oh my God.
Me and Mel's saying is real G's move in silence like lasagna. Thank you, Lil Wayne.
Lil Wayne. I can't. Lil Wayne?
Lil Wayne.
Lil Wayne. Mm-hmm. So we're going to be talking a lot today about complications. So basically I went on my story and I asked all of you guys what you guys wanted to hear this week or for the next like 4 or 5 podcasts. And you guys, one of them was complications, but also uses of Botox, because Botox has been around forever. However, over the past like year or two, we've been using it way more in other places other than the upper face and also the lower face. So we're going to dive deeper into that today. All right, so let's talk about first the look of 3. So the look of 3 is getting Botox to your 11 lines, which are right between your brows, and then the frontalis muscle, which is your forehead, and then the crow's feet, which are around the eyes. So those are the 3 most common areas that people get Botox. A lot of people, I think you'll agree with this, are scared of getting Botox around their eyes. I feel like a lot of people are like, I don't know, I just want my 11s in my forehead. But like once you get your crow's feet done, it's just
life-changing.
Chef's kiss, right? But now we're starting to go down into the lower face. So like bunny lines, DAOs, the neck, and things like that. And a lot of people are interested in treating the neck now because they want to make sure their neck looks like their face.
And I think it's important, like all the areas kind of work together. If we're only treating the forehead and in between the brows, we want to treat around the eyes so that, you know, we don't make you heavy or we don't close off the eyes. We want to open everything up. And same thing with the neck. You know, these muscles work to kind of pull things down, which over time creates the marionette lines, the jowls. So when we treat these muscles, we get a nice lift of the area.
Right, because everything works in harmony. Yeah, I always tell my patients that if you don't get your crow's feet done, like it's fine. We don't have to this time around, but you might notice that that's all you're going to see.
Exactly.
Or they might compensate and that muscle will get stronger.
Right.
Yeah, so it just will look better.
Yeah.
I also feel like lately, don't you feel like people are like scared of filler more?
Oh yeah.
Like, I mean, it's just like social media, TikTok, like all those things.
They want to start with the Botox or the PRP.
Yes.
The natural.
Yeah, which we're all about. But it is kind of a nice gateway to start doing like full face Tox, because it does do so much. Like that woman who did that, she drew the line.
Oh yes,
down her face.
half her face. Yes,
yeah, that was really neat.
Yeah,
and she was like, "I'm going to be a lab rat." It was #science.
And do the Nefertiti and
and she treated just the lower face on one side, and it was so cool to see it because even her left cheek, the side that she was treated, her cheek even appeared more lifted.
And we talked about that in a previous episode about having your patients come back, you know, for a 2-week follow-up, because a lot of the time they might not even notice the difference until you put it next to it and they're like, oh,
so true.
Like, wow, what a change.
And getting before pictures,
Yep.
which sometimes I lack on, but we're getting there. Yeah. So yes, where else do you use Botox in the lower face, Nicole? Like, what are your, like down in Jersey, like where would you say, like, where are you guys at? Okay, this is really good.
Yeah.
In Jersey compared to, I'm in Syracuse, New York, and I feel like, I don't know, it's very similar towns, but I feel like in upstate New York, we're getting there finally. But like, how is it down here? You're just outside the city. Like, what do you, how?
Yeah, definitely. I think people are definitely more open to full face and more units in our area. But full face is like something that we see on the daily now. When patients come in and we do Botox, they're like, oh, you know, I did see online that I could treat, what are these called? They all know DAO, but they're like, they don't know how to say it.
The DAO.
But yeah, so chin, DAO muscles. We are doing a lot of that, like Nefertiti lift now. You know, coming through the platismal bands.
The queen, Nefertiti.
Yeah, right. So yeah, it is common. So I would say 100+ units on a lot of patients.
That's amazing.
Yeah.
Yeah, ever since I took Leslie Fletcher's 75 Obscure courses a year ago, my Botox units have like tripled almost. But I think it just makes you more comfortable like, using it. And obviously if patients trust you, they're like, no, I trust you, do it if you think it works.
I think as trainers too, we see that all the time with people we go and train. They are so afraid to do too many units. And that's why you're not getting the full results or longevity.
100%. And I feel like too, if you're not using the right amount of units, that's how you get Spock brow and things like that too. Because if you're doing it right and you're dosing per the FDA, like 64 units or around that, you should be fine. You should have even brows. They should be lifting simultaneously. One should not be
lifting higher than the other.
Yes.
And like, I mean, I get like 22 units in my forehead. It's all about placement. You don't want to be placing it too close to the brow.
How many fingers is your forehead?
Probably 6.
Oh, get out of
I
here.
have a big ass forehead.
Let's see for a minute. Mine's 4, but I have big hands. Wink. I can't, but
I feel like I'm a 6er.
You're a 6er?
A 5.
Yeah, you're a 5er. But I have a huge forehead too. So like, and that's the other thing when we're assessing patients, like if you just treat here and do 10 units, this will be relaxed, but then you'll be bunchy up here and get those, which I think is a sign of like bad Botox, right? Yeah. And I'm not judging, but you just need more. You need another row above.
Well, and I think too, that's funny. I was just talking about in the last training I did how everyone like thinks Botox is so easy, and I feel like it gets missed in trainings.
It's harder than filler, I think, sometimes. Yeah. Right?
So like no one talks about it, and then no one continues their education on it, and no one learns how these muscles really work. Like the line of convergence, if you're saying high and by that hairline, you actually should get a good amount of lift. So
it's so nice. I know. Hey guys, just popping in to remind you to like, subscribe, and hit the bell for notifications. Also, don't forget to follow us on Instagram, Injector Jon and Aesthetic Nurse Nicole. Thank you so much for watching. And if you have any questions, leave it in the comment section. Wait, let's talk about microtox.
Oh yeah, microtox
has gotten really popular. Do you do that a lot with your patients?
Yeah, so especially in like the neck area. So we'll do like the Nefertiti and kind of really hit the platysmal bands. But if people have a lot of laxity through the front of the neck, we'll come through and do a couple.
What are you reconstituting?
So the microtox, it really depends. 2 to 1, 4 to 1. Yeah.
Oh, yeah. Okay. So 4 to 1 disperse way more. I do 2 to 1 when I do all like the neck in this area, stuff like that. Do you also do microtox around the eyes sometimes?
So the only other place genuinely I do it is like close to the brow. People that have like these really
strong brows and they hit like a little comma.
Yep. And if you don't hit it, that's who will spock, because they have those, they'll pull right at the edge. But yeah, so we'll do a little bit of but that's honestly sometimes a 1-to-1 even there.
Right. Microtox. Hashtag Melissa. Yeah. Strong brows over there.
Strong arch.
Oh yeah, those strong Italian brows, girlfriend.
But speaking of dilutions, we do a 4 to 1 in the underarms. That's an area people don't think of for sweating. It can really. You
can also do it in the traps.
Yep.
Traps are probably a good place so it diffuses more.
Yeah.
And that's another area that's getting really popular is Botox in the traps, scalene area, neck area, and also like through the tempora.
Oh, talk about, because you just did Leslie's, you were the model at Leslie's course.
Oh my God.
Talk about it.
Of course, when I was participating in her training, I was seeing these patients come in and they had like a headband headache already and we were doing their Botox, and I'm like seeing them like already like they're moving better. Their neck is more loose. They said that their headache broke. And I was like, okay, really? Like you're just like, are you just saying this to like,
right.
You know? But then I was like, I need to be the patient. So I was the patient. 100% believe it. Like I had immediate relief. My ears actually popped on both sides, and I had relief of actually my headband headache immediately. I will say later on, I was a little sore in the areas of the injection, but like, that's to be expected.
Right.
But the next day, and even now a week later, so much better. I've not had one headache this week.
Wow.
And I usually get 3 to 4 a week.
Wow.
And the dose she gave me, it was around 230 units total. And that was masseter, tempora muscle, trapezius, scalenes, this whole area.
Wow.
Yeah.
And honestly, that for all those areas, it's not that many units.
It's not.
In reality.
And I've learned that the lethal dose of Botox is like 3,500 units. What?
Oh my God.
There's a lethal dose.
Wow.
Yes, it's important to know it. 3,500 3,500 units. So when people are saying, oh my God, I'm getting 168 units.
It's really not a lot.
It's really not. It's a good dose. It's what you should be getting for the areas that we're treating, but it won't kill you.
Yeah. You won't end up with botulism. Go back and watch our
But if you get
third
the overseas Botox or black market Botox, then maybe you will.
Yeah. People's basements.
Oh my God. Oh,
we won't go back to that conference.
There's a scandal in my area though.
Let's hear about it.
There's just something happening. There's someone who might be getting in trouble. Yeah, that's what I've heard. I don't want to dive deeper into it.
We'll leave it at that.
We'll leave it at that. But it's scary because, and I did not see it coming. Like, I mean, it makes sense. It's going to happen anywhere.
Yeah.
And this person's been doing it, I guess, for a long time. And it's just crazy to think that people are going to get a full syringe for $250.
Oh my God. You got to know at that point you're walking into.
That's how much it costs for us to buy a syringe filler.
Even more.
If not a little bit more.
Yeah.
So, yes. Just
wait, do yours cost you $250? Do yours cost you $250?
I don't know.
Okay, because mine don't. I'm like, I need to get John's rep.
I have to check my rep. Oh God. But yes.
I was gonna say, we just had this week a pharmaceutical rep, like he owns a pharmacy, and he was like, I could get you guys Botox and Latisse and everything, and we were like, no thanks.
Right, we're getting it straight from Allergan, honey.
Yeah, sketchy.
It is
sketchy.
Yes, but back to like microtox in the neck. I think microtox in the neck is very underrated. And I think it really does work.
Yeah.
And I usually tell my patients, I mean, you can get it every 4 months, but I mean, if you do it at least twice a year, I think it really does help. And it's really good for if you have the crepey, just a little bit of crepiness through here, that little looseness even here, like the gobble area. It'll help to just kind of tighten that skin and improve skin texture too. Yep.
And if you do the platysmal bands with it, which if for people watching, if you don't know what platysmal bands are, I have really good ones.
Yes.
So it's these little things that pop out, and that's what's kind of pulling the skin down. So over time, as we age, that's what's creating this downward pull.
And your muscles become more prominent because we lose fat, we lose collagen in the skin. So it's literally skin and muscle, right? So that's why too, the muscles as we get older get more dominant. So we have to relax those muscles that pull down with Botox, and it gently lifts the lower face. Yes. Do you guys do like aqua gold or anything like that? No. You've heard of it?
Yeah.
Yes, I know. The practice I previously worked at before I opened up Tox Pout, I used to do it. It was good.
Yeah.
But I don't know, just in my opinion, get microneedling.
Yeah, exactly.
Microneedling.
Aqua Gold is like a little stamper that you put a little bit of filler, a little bit of Botox, maybe some vitamin C, some kind of serum.
Saline, lidocaine, whatever.
Yeah, and then you stamp it along the skin. Yeah, growth factors. But yeah, we just firmly believe in traditional microneedling.
Yes.
Yeah, it's going to give you more of a result, and how much of that is really getting delivered into the skin.
Right, and it's very superficial. I think it's only like there's 0.6 millimeter, right? And then a 1 millimeter, but yes. Okay.
Yeah, we are actually testing out tomorrow. Me, Melissa, and Brittany are going to do microneedling with Sculptra.
Very nice. That's all the craze right now, actually.
Yeah, so we're going to give that a try.
I love that.
Shout out to Olivia.
I know, Olivia Salmon, if you're watching, one of our besties. She's down in Nashville. But yes, it's actually grown in popularity, I feel like, in aesthetics. Not like huge, but it's like starting.
Yeah, for sure.
Yes, that's great. So as you guys probably have heard of what Sculptra is, Sculptra is a biostimulator. So it's polyallactic acid, which is telling your body to produce its own natural collagen. So it's realigning collagen and elastin fibers to firm and tighten the skin, but also help restore some volume when it's injected under the skin. But what you're talking about is reconstituting the vial, but then putting it on topically and microneedling it in, which is amazing for like acne scarring and retexturizing and all the things. It's amazing.
That was beautiful.
So I'm sorry. I can't. Oh my gosh, that coffee is hitting.
I feel like you probably say that to your patients every day.
Oh, I just love it.
I know.
So passionate about it. But seriously, the coffee's hitting.
Do you need to go to the bathroom?
No, I don't have to pee.
Okay.
For the 4th time this morning. I know.
We can start to go into complications. So let's start talking about Botox. So when you get Botox, we talked a little bit about this.
Yes, Nicole. Yes.
It's the espresso. Oh my God. Okay.
Hold on. I'm going to talk in my straight man voice. Yes. Talk about the complications of Botox.
I'm picturing when you have to use that voice.
Yes, it does come out.
Yeah, I'm sure it does.
It does come out to play. So back to Botox.
Yes.
So
back to business.
Back to business.
No, so we were talking earlier about how you know one brow can sometimes raise higher than the other once your Botox kicks in after 2 weeks.
Don't panic.
Yeah, there's a lot of, I don't want to say a lot, but there's a couple things that can happen with Botox that patients might view as complications when in reality it's just kind of learning your muscles and it's a quick, easy fix. So definitely Spock brows, quick, easy fix. You just unit, drop it down a little. I think the crow's feet on certain people.
That's a tough one.
For injectors, I feel like you really have to do a good assessment on that area because if they have very crepey skin or fat pocketing, if you
lymphatics.
put if a malar mound, if you put Botox through that area, it's going to slow the lymphatics because if you think about it, your muscle every time you blink is helping your lymphatics pump. So if you weaken that, you're going to end up getting a little bit more puffy. You're going to feel like you look more hollow.
Makes sense.
Yeah. So that's something
that's
that
a really good
injectors,
explanation, actually.
Thank you. Yeah. So I feel like that's something that as injectors we have to assess, because if that happens to your patient, you have to wait 3 to 4 months for it to wear off. There's really not much you can do there.
Yes. I also feel, go ahead.
We should put in Melissa's picture right before Christmas.
Yes.
What was that, 2 years ago? She wanted to try something she saw on Instagram, so we tried it.
Oh, tried something she saw on Instagram. This
Don't
sounds
do
good.
that.
Don't do it. Talk to your provider first.
But oh my God, we'll have to put the picture in here because it was like Kourtney Kardashian, that episode when she comes back from the dentist.
And one side it's like drooping.
For 2.5 months.
Like,
it was just, she would smile and one side would not move at all.
oh my God.
So we'll have to upload some pictures of that.
Yes.
But it wore off 2 months, I would say, and it was gone.
I feel like too, if you've never had Botox before, it's very normal. And first of all, any like new patient, you get a 2 to 3 week follow-up. Just make sure everything sets well, because we want to make sure you're happy. You're a walking billboard for all of us. But also I feel like it's normal. Your muscles are so strong for so many years that you might need a touch up. Right.
Yeah.
And then after that touch up, then we know like what to do next time. And don't the muscles get like weaker as time goes on? So sometimes you don't, it's a myth that you won't need less.
Yeah.
I think will need less.
Because patients always say that. They're like, well, next time will I need less? Like, no, it's the same dose many years until eventually you may, weaken that muscle enough where you can drop 5 to 10 units. It's not going to be crazy. Or like go
longer maybe.
Right. Longevity wise, that's huge too. Yeah.
So just like a word for the wise. So like if you get Botox and you're like one brow's a little bit higher, definitely tell your injector, call the provider, because it like sometimes it like hurts my feeling. We've all had a couple of patients that are like, oh my God, I'll never go back there. One brow was higher than the other. I never called. You didn't call. You should call, because it's a quick fix. Going to a trusted provider, they know what to do, how to fix it. Yeah, and people immediately think it's a complication or, oh my gosh, that they had a bad reaction. Like it's just how your muscles responded. 100%. Yeah. Yes. To tackle the under eye a little bit. Yes, I myself, especially in the previous podcast episodes, my Botox settled and I did microtox underneath, and I did my jelly roll, which I love. It helps a lot with the fine lines and wrinkles. However, when everything's relaxed from here up, sometimes you kind of look dead a little bit. Yeah. But after like 3 or 4 weeks, it settles a little bit and it looks more natural when you smile. Yeah. So, but there's some patients that you do it once for them and they're like, never again. They hate it. They're like, it changed my smile or like the way they saw themselves in a picture. Yeah. It honestly makes me look more tired. I could pull some pictures too. Yeah. Yes. It gives me like a double bubble under my eyes. I like to call it my double bubble. It is. It's a double bubble. Love it. Yes. So obviously those are easy, quick fixes. Botox. Quick fixes. And like those we said, aren't complications. Yeah. And if you have a decent Botox complication, it wears off. 3 to 4 months, those more adverse events with Botox are like the lid ptosis or crooked smile. I thank God we have things like Upneek now. Yes. Upneek is wonderful. And then also you can, if it's placed correctly, it's off label. So Allergan, if you're watching, but you can place a little bit of Botox laterally on the upper eyelid and also medially. And that just helps to lift the eye. God forbid that happens. And Upneek is just a eye drop basically that helps kind of lift that muscle as well. That Mueller's muscle. Yeah. But so besides those, obviously when we stem into filler, there's a little bit more of that complication potential. And is it a bruise? Yeah. Is it an occlusion? Right. And a lot of people were asking for us to go over complication management. So I feel like we should maybe just list some complications and how we're prepared to treat them. So I would say your first and foremost is swelling, bruising, all your common stuff. That's very normal. Some patients will swell a lot more than other patients. Yeah. We all get that picture every now and then of a patient like with their lips touching their nose. Yes. Some people just react more. They do. If you have to, you could do a steroid or Zyrtec, something to bring it down. Right. Bruising is very common. It's usually pretty small. Some people can have a hematoma, which could be large and I usually, and I think you agree, like icing, like I usually tell my patients to ice only if you're in pain, ice. If you have a little soft tissue, like trauma or swelling from what we did, ice it, but don't over ice it. Because if you do over ice it, sometimes the filler won't settle well. Right. So I usually tell my patients that.
Yeah, and we have like the little gel packs, so I feel like
Cute.
those never get cold enough to cause an issue, but it's enough to make the patient feel comfortable.
Yes.
But yeah, so stemming out of bruising, then we have the occlusion potential, which definitely as a provider, I feel like you need to know what to assess and how to assess and what you're looking for, because even a giant bruise sometimes could look like it has delayed refill.
100%.
You really have to kind of take your time. And if you are checking for refill, be
Press
pushing
hard.
nice and hard and holding it for like a good 5 to 10 seconds and letting go and watching for that, cap refill.
Same thing. And I usually, if I'm ever concerned, I have patients send me pictures like a couple hours later, then that night, then even the following morning, just to make sure. If you're that worried, I bring you back the next day, things like that. But I always carry like 10 to 12 boxes of Hyaluronic in my office just in case. And for those of you that don't know what Hyaluronic is, it's actually an enzyme, hyaluronidase, which is actually carried in the hospitals too. Like if you get an IV infiltrate in the hospital, they use hyaluronidase to break down like the antibiotic, so that way you don't have a reaction to it, but it breaks down filler. So in a good trusted practice, they have that. So in case that there is an occlusion, or even if you're worried, if it's just a bruise that you're like, I just don't feel right, then we can dissolve it and everything will go back to normal. And occlusions, they sound scary, but most of them are caught early, and if they're caught early, everything is fine. Yeah.
And that's the issue, is if your provider is telling you, oh, don't worry about it, and you have a gut instinct that you're in severe pain, there's something wrong with your tissue, it does not look normal, you should get a second opinion, because the longer something goes on, the harder it is to treat. But that being said, sometimes you don't have to dissolve an occlusion. If it's a mild occlusion with a very thin
like
filler,
pressure.
Right, it could be like a spasm or compression, where your body with heat and aspirin could probably clear it itself.
And a lot of people are probably wondering heat, but heat vasodilates, right? So it's going to allow more blood flow to get to the area. And sometimes because the area might be so delicate, it could just be because we did maybe not a good amount of filler, but just enough filler to like compress an area where there's a vessel. And when the soft tissue swelling goes down just from the needle trauma, then everything normally normalizes. But with heat, and like you said, that helps with that.
Right. Have you had an occlusion?
Oh, I'm not kidding.
Never?
Knock on wood. And it will happen because it happens to all of us, but knock on wood, I have not
if
had
it's
an
when,
occlusion. Yes, it's when.
Yeah. Personally, I've had a very small one in kind of like the pre-jowl area.
Okay.
Hyaluronic completely gone.
Amazing.
No issues. Recently, when at our staff injection day, I felt like we could have potentially had one in the cheek area. And we did heat, aspirin. Obviously we're seeing her every day because she worked here. But cleared itself totally fine.
So with just heat and aspirin?
Yeah. Yep.
Oh, amazing.
And
no
it was a very large bruise. No nitropace. A little bit of massage.
Love.
And then in the past, I had worked with an injector where we had a pretty decent occlusion in the jawline, and it took like 14 vials of Hyaluronic.
Wow.
And we did nitro-paste.
Now, what's when you're using hyaluronidase, right? Are you injecting it like you're doing filler? Are you kind of like fanning it in the area?
Yeah.
Kind of?
Yeah. And Hyaluronic is permeable. So as long as you're within the area, it should be able to
into the vessel.
Exactly.
And it'll break it down.
So just flooding the area. One of the ways Julie Kaplan says is, you can fish and like aspirate with your Hyaluronic needle and look for blood.
Yes. I've seen her do that.
Yeah.
That's really cool.
Yeah. So I think she numbs the patients beforehand with some lidocaine.
Yeah, because hyaluronidase is an enzyme. It burns. Yeah, especially if it's in the lip. Like I usually do a dental block before I do any hyaluronidase. But
You're so nice. Dental blocks.
I am. It's the Aquarius in me, people pleaser.
But yeah, so definitely Hyaluronic for sure.
Yes.
We both have little crash carts. We keep EpiPens. Tons of different medications that will help vasodilate.
Yes.
Some are specific to the eyes, some are specific to other areas.
Nitro-paste is one of them.
Yeah.
A lot of people know what that is.
There is a great resource. I'm going to have to look at my phone. I'm sorry, because I don't remember the lady's Instagram. And I think it's such a good...
Especially if you're an injector like by yourself in practice, right? That you can like reference.
Right. Yeah. Medical Aesthetic Institute. I'm sorry, Medical Aesthetic Art Institute. Her name is Yvonne.
I'll have to write this down, actually. This is cool.
But yeah, she'll sell like a kit. It doesn't come with the meds, but it comes with the entire list. And it comes with the little kit, and you can basically fill it yourself. You buy everything off Henry Schein or McKesson, whatever you use. And then it comes with all the protocols. So that's a great
amazing
resource as well.
Also, Leslie Fletcher, she made an entire protocol,
Really?
like handbook. So you can actually purchase it from her website.
That's perfect.
I did that.
Yep.
Saved so much time. And I think it was like $2,500, but it was so worth it. It's all like, you can go in and you can edit everything, but you can add your logo. You can add like, different things that services that you offer. It saved so much time.
Yep.
So if you are an injector and you're watching this, or business owner and you're trying to save time, definitely consider doing that, because it was totally worth it.
Yeah.
And the protocols are basically like for us to reference if something were to go wrong, or like if, like a newer injector or newer staff member needs to reference something.
Gives them something to follow.
Yes, exactly.
Besides Hyaluronics, the medications, the EpiPens, the Solumedrol, steroids.
Yes.
Another thing could be cold sores. So if someone suffers from cold sore outbreaks, if you don't pre-medicate and you're doing a lip filler treatment, sometimes you can have a pretty decent outbreak.
Yes.
And
we want to minimize that. We don't want any outbreak or any type of like wound after doing filler. But yeah, Valtrex or Valcyclovir.
Yeah, we typically do Valtrex 1 gram and like 2 doses before, 2 doses after. And then we call them extras in case something arises.
I'm psychotic, and I do the 1 gram twice a day, like 2 days before. I can have them continue a 7-day course just in case.
Yeah, yeah.
But that works too. That's the prophylactic dosing.
Yeah, yeah, yeah. So that, we keep that in the office just in case someone doesn't give us a heads up, so we can give them a dose beforehand.
Okay, let's talk about delayed onset nodules, because I actually had 2 patients that had delayed onset nodules, but it was from coronavirus or COVID. Wow. Yes. And one of them resolved with just like heat and aspirin. And I actually prescribed her, she gets cold sores very frequently. So I sent her that. It almost looked like dermatitis, like around her lip, but it resolved within a week. The second patient, I did filler on, lip filler, settled beautifully. A month later, get a call. She had painful nodules in her lips, swelling all around her mouth, and it came out of nowhere, and brought her in. She told me she had COVID, and filler can respond to like a systemic issue in the body. So if you have that's why we flag for like autoimmune disease.
Yes.
That's also something else. So if you have lupus, rheumatoid arthritis, Sjogren's, what are other ones? Those are the top 3 that I can think of. It's good for us to know, because if you are in an active flare, Crohn's, ulcerative colitis, if you have an active flare, we kind of avoid doing filler around that time until you're more stable, because the filler can respond to that because your inflammatory markers are heightened. So
as an injector too, if someone does have autoimmune disorders, you're probably best steering away from those long lasting fillers and using something that's not so tightly cross-linked.
Right.
Just to kind of avoid long-term issues like delayed onset nodules and things of that nature.
Yeah. So this patient came in and saw her, and I immediately put her on a Medrol dose pack, but then I switched it to high dose, like oral prednisone. I do, like you said, I have IV Solumedrol or methylprednisone in my office, which is you can either give it IV, but you can also give it IM. I gave her a one-time dose of like 125 milligrams just to get her kicked off and ready. And that brought down so much of the inflammation. And then she started the oral prednisone after that. And then we slowly dissolved her. I did like intralesional steroid with hyaluronidase, and over time it just got better. But yeah, that's also a complication that can happen. And
I think it's important to treat first and not just go straight for the Hyaluronics.
100%.
Sometimes you can treat them with oral medications and not have to even inject them. But if you inject in a active flare, it can just make things worse. So treating with steroid first or an antibiotic first, and waiting till that comes down, and then treating the nodule with Hyaluronics or steroid.
This is also why we tell patients not to use like your old chapsticks or old lip balms too, because if you have fresh filler with all those needle pokes, you go in your car, you use an old makeup brush, or you use your lip balm that was already used, that bacteria can get right in, and it can cause like pustules, or it can cause nodules as well.
It takes a good 24 hours for those little spots to close up. And sometimes people don't even think about like pets, your babies,
oh my God,
like
your dog licking your lips, fresh lips.
Yeah. And you can't,
fresh face.
you just can't go kissing everything after.
You don't know where they've been licking. Well, I do. But
I was going to say, I do.
Yeah. We love our fur babies, but not the first 24 to 48 hours on the lips.
No, absolutely not.
The face.
Yeah. So I think obviously the delayed onset nodules or nodules in general, but also infection.
Yes.
You know, if patients don't follow aftercare, or it could just be anything sometimes. And I think too, you know, we do an aseptic technique, but we're not sterile. So I always wipe my gloves with alcohol prior to starting injecting, because you are touching a lot of things before you go to the patient.
You are. And while you're doing someone's lips too, or even if you're doing their face, all the time they might have an itch. They go and they like rub a certain area, and then you forget to wipe, and then you know, inject the lips. They're constantly licking their lips. Do you have patients rinse their mouth out before?
I don't.
We started.
Yeah.
We're going to really, really instill it now because it's so important. Because bad oral hygiene. I mean, if we're doing your lips, and then you just sometimes want to lick your lips like during it, because it just feels weird, and then you go ahead and forget to wipe it with like Purison or like alcohol, and then you have
bacteria. So that's another thing, is having the patients avoid the dentist for 2 weeks. Before and after. And patients always ask me like, why is that? Because it's going to mess up the filler, because they're like pulling out my mouth. I'm like, no, because there's so much bacteria in your mouth that you don't even know exists, and it wouldn't be on your face normally. So if you go to the dentist and unleash all that bacteria, and then we inject your lips, it's still sitting in the area. So that's why you want to give it a good 2 weeks, prevent any infection.
100%.
I think it's important to say too, like as a new injector, especially, like don't be afraid of the complications. And it is good to be afraid, you know, we should be always educating and making sure that we're
humble.
Right. Exactly. Because things happen. But making sure that you educate yourself and always continue your education, and just knowing how to handle a complication, you know, if they do arise, because they will arise, and having, you know, mentors. Leslie Fletcher's a great one, Yvonne that I just shared earlier, and just knowing how to care for a patient if something like that happens.
Yes. I love that. It's a perfect explanation. All right, guys. Well, thank you so much for tuning in to this week's episode of Fill Me In. We love you guys and appreciate your support so much.
See you next time.
Bye.